Hi, my name is Dr. Leela Landowski, and today I'm delighted to be joined by Dr. Mark Campbell. So Dr. Mark Campbell originally hails from America, training as an internal physician at the Mayo Clinic, but today we're really lucky to be joined by him. He's now working as a general physician in the clinic setting. So thank you for joining us here today, Mark.
No, thank you. It's really my pleasure.
So Mark's here today to talk about the issue of geriatric polypharmacy. So Mark, what actually is polypharmacy and why is it such an issue, especially in an older population?
Yeah, polypharmacy is pretty much what it sounds like. It just means that people at times are on too many medications. I think we see it in the geriatric population in particular because as you get older, you tend to accumulate more diagnoses. And I think especially in Western medicine, there's a tendency to try to treat most things with pharmacotherapy if there's an option available. So I do think that over time, that's why we're seeing more and more polypharmacy in an aging population. Look, I think it really has to do with some of the harm that can come from being on multiple drugs. And we don't tend to think of that. We tend to think of drugs, especially pharmaceutical drugs, as things that are good for us and that, every time it's what the doctor has prescribed. And I think that especially here in Australia, we see a lot of trust in the medical profession. So it's at times a little confronting to think about too many drugs as being a bad thing, but that certainly can be the case. And I think we'll go through a lot of the reasons why that might be. Well, I think what we see is that our bodies change as we get older. And when we're older, we're not really able to handle some of these medications like you are when you're a younger person. There's this whole concept of pharmacokinetics versus pharmacodynamics that comes into play. And pharmacokinetics really refers to the body's effect on the drug that we're taking. And as you get older, all the aspects of pharmacokinetics, so absorption, distribution, excretion, metabolism, they all change. And they change to be a little bit less efficient in general.
So given this, what sort of changes might we see in terms of drug absorption in an elderly patient?
I think when we think about taking medications, we tend to think about taking tablets.
Yep.
Right? And I think as people get older, there are a few things to consider from the physiology. And one is that gastric emptying slows down as you get older. So what goes into your stomach doesn't come out of the stomach quite as fast. Also, the acid that's produced by the stomach isn't produced in the same quantity when you're older as when you're younger, and that will definitely affect absorption of medicine as well. Even before you get to that point, just the swallow reflex itself does become more impaired as you get older. And a lot of times we will see that elderly people just have a hard time in general swallowing pills.
So what sort of metabolic changes might we see in an elderly patient?
It's really hard to generalize because I think that when we talk about people that are a little bit older, there's really a wide range of physiology that you see. Some people are really robust, well into their 80s and 90s. And there are other individuals out there that are a little bit more frail. And I think a lot of times what you see on the outside is probably reflective of what's going on inside as well. In general, we can say that the metabolism slows down as you age. You lose liver mass as you age as well. And the liver is really responsible for a lot of the metabolic processes that are going on in our bodies. Not just in terms of the chemical reactions in that, but the liver also, it also produces carrier proteins that are responsible for moving things all around the body. So you can imagine as you get a little bit older that things just aren't working as efficiently.
So that's metabolism. What sort of changes might we expect to see in terms of excretion that might affect the pharmacodynamics of a drug in an elderly patient?
Right. Well, as you get older, your renal function, your kidney function tends to decrease as well. And I've been told in the past that over the age of about 45, 50, you tend to lose about 1% of your renal function per year. And so for drugs that are renally excreted, you can imagine that if they're dependent on a pathway that's maybe half as efficient as it should be, that they can tend to build up in the bloodstream and reach at times toxic levels and be quite dangerous.
So are there particular drugs in that scenario that you would be mindful of in an elderly patient?
Yeah, there are a couple that we see pretty frequently. One is lithium and another is digoxin, which is a drug that's used to treat heart arrhythmias at times.
So as we're aging, obviously we're going to be having changes in our body composition, in our circulatory function. Now, how is that going to affect the pharmacokinetics, especially in an elderly patient?
Well, as you get older, your cardiac output, it's just not as efficient as when you're younger. And also your ability to return blood from your arms and legs, it's not as good when you're older because the veins aren't working as efficiently. As you get older also, you see that you tend to gain more fat and lose lean muscle. And that will also have an impact on how long drugs stay in the system and how effective they are.
Is that dependent on whether the drug is lipophilic, for example? Or?
Absolutely it
Right,
is. Yeah, absolutely.
So Mark, how often do you see drugs prescribed inappropriately in the workplace as a clinician?
Yeah, unfortunately it happens quite a bit. And I think that doctors have good intentions. A lot of times patients will be prescribed a drug, but maybe stay on it longer than they should. I think a mistake also happens where a person can be on a drug for a long time and not at times have that drug reviewed to see if it's still appropriate. Now, research indicates that up to about 40% of Australians are prescribed at least one inappropriate drug.
Wow, could you give us some examples of those?
Yeah, and I think a really good example of that in my day-to-day practice is medications like ibuprofen or naproxen. They're so-called NSAIDs or non-steroidals, we call them. And a lot of times what will happen is a patient will be prescribed an NSAID maybe because they've bumped their elbow and there's some pain. And for whatever reason, they remain on that drug for a little bit longer than they should. Well, this class of drugs can cause problems with the kidneys of older people and younger people too. It can also cause some gastric bleeding and things like that. And so it can be pretty dangerous. Again, people have been prescribed these drugs with the very best of intentions. But the fact that they remain on them for longer than they should does get to be dangerous.
So Mark, are there any particular drugs that we need to be really wary of in the elderly population?
Yeah, I tend to worry about blood pressure drugs in particular, antihypertensives. A lot of times we'll see patients prescribed a whole slew of these when they're diagnosed with something like heart failure, because by guidelines it's appropriate therapy. So it's very normal that we might see a person prescribed an ACE inhibitor to lower blood pressure, a beta blocker, which can lower blood pressure but also helps with remodeling of the heart, and also a diuretic medication to get excess fluid off. And lower blood pressure and help take a little bit of pressure off the heart. You can imagine that if somebody started on all three of these medications at once, and if they're not being monitored very closely, they can have very unsafe drops in blood pressure, which leads to increased falls, which means they come and see me in the hospital.
So on that note, I wonder, could you give us a case example of a patient that has had polypharmacy?
Yeah, there was a patient I saw probably about a year ago who had been started on fluoxetine, which is Prozac, for treatment of depression. In the meantime, they also developed some back pain and were started on tramadol by the GP as well to treat the back pain. Came to light after the fact that the patient was also taking an over-the-counter supplement called St. John's wort, again to help with anxiety and depression and mood. Well, the combination of those three things led this person to come into hospital with altered mental status, headaches, high blood pressure, super high heart rate, high fever. It took us a couple days to figure out that what they actually had was serotonin syndrome, which was 100% because of the medications that they were on.
Could you give us some other examples of drug interactions?
Yeah, a lot of times we'll see it with a medication called warfarin. Now, you might have heard of warfarin before as something that's used to stop clots from forming and prevent strokes in people with atrial fibrillation, which is a heart arrhythmia that's very common. The thing that's challenging about warfarin is almost everything interacts with it. To the point where it's not only other medications that you worry about, it's diet as well. So, if you're a person that likes to eat a lot of salads and things like that are high in vitamin K, and you go on warfarin, the warfarin doesn't work as well because vitamin K is an antagonist of warfarin. On the other hand, if you're somebody that has never had a salad in your life and you've been on warfarin and all of a sudden somebody feeds you spinach, then you can see that, again, the effect of the warfarin is diminished immediately and it puts you at higher risk of stroke. There are other medications as well that can interact with warfarin, particularly in terms of causing a higher propensity for bleeds. I think I already mentioned non-steroidal drugs like ibuprofen and naproxen as an example of that. Again, we see it almost every day in the hospital.
So Mark, what are some other things that we need to take into account with polypharmacy?
Look, I think it comes down to the individual patient and looking at the characteristics that each person in front of you has. I've had incidents in the past where I've explained to a patient the drug they're going to be on, how often they need to take it, exactly what needs to be done, only to find out later that even though they were smiling and nodding and seemed to understand, that they were profoundly deaf and they couldn't hear a word that I'd said. You know, we see the same thing with visual impairment. Here in Tasmania, we have a very high illiteracy rate. And so a lot of times if we expect that a person can read the prescription that we've given them, that's our expectation. But a lot of times it doesn't match the reality of what's going on. So I think it is really important to take the individual into account. I think often we make our medication regimens too complicated. We say, okay, you have to take 3 medications 3 times a day, before meals, after meals, with meals, and we expect people to really adhere to this. Well, the reality is that they don't. And so I think this is truly an issue.
So are there any common culprits that are likely to cause adverse events in elderly patients?
Right. Yeah, there are quite a few classes of drugs that can, and I think we've already hit on a couple of them. So certainly the antihypertensives, blood pressure medications, diuretics, that kind of thing. We've talked a little bit about non-steroidal drugs, things like ibuprofen and naproxen. Benzodiazepines, medications like Valium and Xanax can cause falls, increased risk of possibly dementia in elderly people as well. Painkillers, things like opiates such as morphine and hydromorphone and tramadol, all can increase the risk of falls and cognitive impairment as well.
So Mark, you made a super clear case as to why geriatric polypharmacy is an issue. What are things that we can do about this?
Well, what we know from research is that the more time and effort you put into addressing this, the better the health outcomes at the end. So what we do see in the health system is more engagement from pharmacists. I think if a patient has a really good relationship with a GP, this does go a long way also toward helping to reduce polypharmacy. One of the disturbing trends in healthcare at the moment is that people don't have a GP or a doctor that follows them necessarily over a long period of time. And this is associated with medication errors. It certainly is. So I think engagement by a good GP, involvement of a clinical pharmacist, also simplification of medication regimens can go a long way toward preventing some of these problems from happening in the first place.
So Mark, you've taken us through the principles of geriatric polypharmacy. You've explained how the elderly are more likely to have drug-to-drug interactions, more issues with how drugs behave in the body and how they might build up in the body, and how we might be more likely to have adverse events as a result of those pharmacokinetic changes, those inappropriate prescribing issues that we may encounter as we get older, the complexity with the regimen of the administration of those drugs, issues with adherence. So Mark, thank you so much for taking the time out of your day today to talk to us about this really complex issue.
No, it really is my pleasure. Thank you, Leela.